there are reports of perinatally transmitted chlamydia infection persisting up to 3 years. So if I get a 2-year-old and I get this positive and the mom has a history of chlamydia, it's so difficult for us to figure it out that I can take you something else has to occur in between. So just keep this in mind that this is out there. And again, for this, the available DNA probes have also been admitted where cultures are not available. So this is important that you cannot do this and you have to repeat it twice for a confirmatory test. For trick, in older than 1 year, this isolation raises serious suspicions about abuse. But clear evidence of the age at which vertical transmission can be ruled out is lacking. Again, you have to look at true cells. So we had a 2-year-old that the lab reported at 11 p.m. that it is positive for trick in a 2-year-old in a urine sample. ACS was called, everybody was called. Next day, the pathologist looked at it and said, nah, it's not true cells. The point I'm trying to make it is that it is also operator dependent on what you are looking at. So there's no, unless you identify something like this on a report, make sure somebody qualified, couple of people have looked at it before you jump the gun and throw the book at the family, because that is really a huge problem we ran into on that one. So again, talking about warts, HPVs cannot assume a cutoff age above which vertical transmission can be ruled out given lack of adequate studies. Problem is that vertical transmission, inoculation from cutaneous warts, auto-inoculation has all been demonstrated. So HPV genital typing can be useful, but again, suspected sexual abuse in children are very limited proof in this age group also. For the genital herpes, again, type 1 and type 2 does this. Again, it can go from both from sexual and non-sexual contact. The infection itself is not seen as a decisive evidence of abuse. But again, if you see this without any other evidence of different transmission, then of course you should consider that. But again, difficult. Management is of course all this above, and then hydrocortisone to break the itching cycle. Treat constipation if it is culture positive, treat accordingly. Pinworm with bendazole, I think it is back in the market, but then under the name of Vermox, it's available now. But again, you can use two other, albendazole and pyrantyl palmoid, both can be used for that. Again, it's very specific for strep. You can use amoxicillin if it's non-typable, augmentin for candida, for yersinia, for staph, for GC trichomonas, and of course this is it. So, now this occurs again and again. So if a patient comes back again and again, I think we need to go back and take the history again, reevaluate some things, look at the allergic reaction that may be having to the medication you are giving actually. And then in studies they have found for recurrent vulvovaginitis, anaerobes to be the main category, and they would suggest a course of metronidazole. Of course, make sure this is not the component going on. And if this is an issue, then we can do an examination and anesthesia for this. Specifically for this, should distinction between non-specific and infectious. The most common pathogens are these three. Specific should not only be used if you get something like this. And of course, if you have concern about it, then of course you need to worry about that. We'll stop here and take questions. Thank you so much. Any questions, any comments, my fellows, anything that you would like to add on?
If you do chain cultures for STI, you don't need to treat pre-convalescent patient. We can follow up because they need a confirmation test, and if you've already started antibiotics, you may see that result. So you don't have to treat. They're not going anywhere. 2 days is not going to make a difference in that child, but whether they have it. And then I don't know the answer to this, but for genital herpes, they say valsacrovir, but I don't know the youngest age.
Say that again?
Valsacrovir instead of acyclovir?
Oh, I don't. I'm such a great fan of acyclovir.
They have to be close followed. They have to be close followed. At least.
Pretty good. Anything else that you have seen pre-pubertal that you would like to talk about next couple of minutes? Anybody have seen something different or something else at that particular age that was a challenge or something like that?
Maybe paraphimosis, that's another.
Yeah. I didn't want to go into surgical part of it, because once you go into the surgicals, there are so many surgicals of looking at inguinal hernias, and then that's why I didn't want you to touch base on that. But yeah, just one of those things is to look at
paraphimosis. You need appearance and
So uncircumcised male, you can see the retractions, and people do anything from salt to sugar to cold compress to nerve block to squeeze. I have never failed. I have seen so many, and a cold compress and a firm squeeze for unlimited time on the penis. Generally, I am able to decrease the swelling, and I'm able to push it right back in place without any issues in so many. So it is time tested for me. I've never tried sugar. People in my adult colleagues swear by it, that's the way to pour on it to decrease the edema. But for me, cold compress and squeezing has worked almost always.
The other thing,
Yes?